Okay, good evening, everyone. Please take your seats. We'll start now. So, welcome. My name is Michal Kazachkin. I'm a member of the Global Commission on Drug Policy, and on behalf of the Commission, I'd like to welcome you to this session on supervised drug consumption facilities. I actually like to call them safe injection or safe consumption rooms or facilities. I like the word safe because it is about providing people safety in when they inject or use. It is about reducing overdoses, but it's also about providing a safe space, a space safe from the repressive environment. So this is what I call the paradox. The environment is about repression, prohibition, and there is our governments that accept to create like an island, a sort of extraterritorial space with immunity, like an embassy, yes? A health embassy, if you wish. And so what does this mean? Is it a paradox? Is it hypocrisy? Or is it really that by accepting to create a safe injection or consumption room, a government will acknowledge that the health of an individual and the health of a community is prevailing over the repressive environment? Does it mean that those governments recognize the primacy of health for drug policy? So that's how I see the issue at a time when, as you know, it is at the heart of fierce political battles, still here in Europe, including in my own country, France, but of course it is in the US, in Canada, and in many other places of the world. So we will have perspectives from France, from the US, from Portugal, where this has been a debate and is still debated, even though Portugal has been a leader in progressive drug policy reforms for many years. We'll have a picture about Europe. And let's go right into the session now, because we have only 45 minutes ahead of us, or 40 minutes ahead of us. First speaker will be Marie Geoffroy-Roustide, who is with the INSERM, the French National Institute for Medical Research, and who has published extensively on this and related issues. Marie.
It works. So thank you, Michel and Jennifer, for inviting me to speak about drug consumption rooms, one of my favorite topics. And one of my favorite topics because I am a social scientist, and drug consumption rooms symbolize paradox. So that's why I like to speak about this topic. So I will speak from a French perspective because I'm French, and that's a country that I know better than others, even if I'm also involved in other projects. So some elements about France, because I'm not sure that all of the audience know how harm reduction is implemented in France. So to begin, I would like to stress that France is often presented as a model for harm reduction because contrary to other countries, and especially contrary to the United States, we have a sustainable harm reduction policy because harm reduction is public funded in France. So that means that France invests a lot on harm reduction. But despite this, but at the same time, we have also one of the most repressive law towards drug use in Europe. And inject drug use, and especially injecting drug use, is stigmatized, is criminalized, stigmatized in France. And in the drug consumption rooms in France have been implemented only in 2016. So we have only one in Paris and one in Strasbourg. And if we make a comparison with Switzerland, Switzerland decided to implement a drug consumption room 30 years before us. So why drug consumption rooms are so difficult to implement in my country? So the first reason is this paradox between public health and public order. So I have to give you some historical elements. So in France, the law on drug use have been voted in 1970, just after the events, the students' events on May 2068. So that means that French politicians have decided to criminalize drug use because they thought that at this time that criminalizing drug use will be a way to stop the process of protest, because people at the government thought that all young people were cannabis users, and they thought that if they put cannabis users in prison, they will have less protest in the streets. So the fact that the French law about drug use has been framed is this specific political protest moment influenced still today the French drug policy. And each time a French government wants to be innovative on drug use and to implement harm reduction and especially drug consumption rooms, there is always this fear of being considered as favoring drug use among young people. So there are a lot of ideological reasons that impede the French government to develop drug policy. In the media discourse and in the political discourse, there is always a confusion between implementing and disseminating drug consumption rooms that are designed for people who inject drugs, and favoring drug use and especially cannabis use among young adolescents. So there is always this confusion. And that's why this confusion that is very present is one of the reasons that drug consumption rooms are always treated as an ideological question and not as a public health question. So that's the first paradox and reason why drug consumption rooms are difficult to implement in my country. Another thing that is also a paradox is that the French government publicly explain all the time that they want now to have drug policies defined by scientific evidence. So all the time we have our French government who said we want now to have drug policy based on evidence-based from scientific publication. And it works quite well for different topics, but not for drug consumption rooms, because this topic is always considered as an emotional topic and not as a scientific topic. It's always considered as an emotional topic because the voices that are considered as the most important for taking a decision for implementing drug consumption rooms in France are not the voices of people who inject drugs, neither the voices of harm reduction providers. all the voices that are considered as the most important are the voices of the residents who live in area where we have a open drug scene. For example, we did a media analysis for an evaluation of drug consumption rooms, and we highlighted that the voices of people who use drugs were 25 less represented than the voices of residents, for example. And another paradox also, another paradox that is also important to highlight is that even if the French government is very concerned by the opinion of the French population, when we look at studies that have been done, quantitative studies that have been done on the social acceptance of drug consumption rooms in France, we have 80% of French people, the French population, that is in favor of drug consumption rooms. So despite this, our French government is still reluctant to implement drug consumption room because it took too much attention to the media discourse, who only highlight in France the opponents, and at the opposite, in the qualitative surveys that I have done with my team on the social acceptance of drug consumption rooms, for example, among residents, we showed that when we do semi-structured interviews with people who live near the area where there were an open drug scene in Paris, and now there is a drug consumption room at Gare du Nord, the discourse of the residents are very diverse. A large majority of them are in favor of drug consumption rooms. They say that in semi-structured interviews that they are reassured by the fact that drug consumption rooms exist because they can contact a harm reduction provider when they see somebody inject in public space, and before they were not able to do that, and they were alone to face with public disorder related to injecting drug use. So one of the problems, I think, is also the representation of injecting drug use that is led by the media discourse in France, that only wants to give the voice to opponents that are not interested by the voices of people with lived experience. And the last thing that is very also important for me to share with you is the fact that I think that one of the limitations of the French model that explain why drug consumption rooms are so difficult to implement is that we have a very biomedicalized model of harm reduction in France. This biomedicalized model of harm reduction is only focused on is mainly focused on the availability of OAT, and it doesn't address enough social justice, the social justice question, and also the rights of people who inject drug. And when we listen to the voices yeah.
It's about time, yeah.
Okay, so I can just, the last thing. So when we listen to the voices in semi-structured interview of people with lived experience, they told us that they feel being protected in these spaces, and I think that it's very important now also to listen to these voices. Sorry for...
Thank you very much. No, thank you. Thank you very much. Marie, I think I agree with everything you've said, except that OAT is not a harm reduction, it's treatment of opioid dependence. Let's debate about that later. So next speaker is Brandon Marshall, who is a professor of epidemiology at Brown University School of Public Health in the US and the founding director of People, Place, and Health Collective. Brandon.
Thank you so much. I'm thrilled to be here, but have the rather unfortunate job of providing the U.S. perspective on this issue. So I was very fortunate to serve on the team that evaluated the first supervised consumption site that opened in Vancouver in 2003, and now lead the first federally funded study of overdose prevention centers that are opening in the United States. You know, I like the term sanctuary. That's how I view overdose prevention centers, as a sanctuary from what in the US is a racist and structurally violent drug policy environment. You know, I think that's true in many countries, but nowhere more true than in the United States. These facilities also provide a lot of other wraparound services and support for people, including medical care. And I think that's particularly important in the US context when we have a fragmented healthcare system in which people who use drugs frequently experience discrimination and other exclusionary practices. And many people do not have health insurance at all, right? And so that greatly limits their access to life-saving medications like methadone and buprenorphine. So in the next few minutes or so, I'm going to talk about the status of supervised consumption sites in the US and then address this paradox. So as the overdose crisis in the US has grown to unprecedented heights, we have seen positive developments in terms of implementation of supervised consumption sites in some US states. The first two publicly recognized supervised consumption facilities opened in New York City in 2021. They're in operation today. And the state of Rhode Island, my home state, was the first to authorize supervised consumption sites through legislation also in 2021. And the sites are slated to open in 2024. Our state was also the first to provide, through this law, a formal regulatory pathway to their implementation, and the state is supporting the implementation through over $2 million in funds from its settlements against opioid manufacturers and distributors. And finally, more recently, the state of Minnesota has authorized overdose prevention centers through an appropriations bill as part of a larger package of over $55 million in grants supporting harm reduction programs. So there's certainly progress in some states, but all of this is taking place in a very hostile federal policy landscape. The Trump administration sued an organization hoping to open a supervised consumption site in Philadelphia, and that court case is actually still ongoing. More recently, the US attorney in the Southern District of New York threatened to close the supervised consumption sites that are currently operating in New York City in an interview with the New York Times. So this paradox that we're discussing is very real in the United States, and I think is having a negative influence on their implementation in other states, is certainly having a chilling effect on organizations' ability to open supervised consumption sites in other jurisdictions. You know, one key challenge for us federally is a 1986 law known colloquially as the Crack House Statute. This makes it illegal to essentially own, operate, or lease any space in which drug use is knowingly happening. And that law applies to employees, landlords, or people who may even volunteer at a space where drugs are knowingly be consumed. Now, the law was not written to apply to supervised consumption sites, you might argue, but this is the challenge, right, is that this law is on the books, and it is not clear federally the extent to which supervised consumption sites are legal in our context. This is different, I want to highlight, from the Canadian context, which all along provided a pathway to open supervised consumption sites through a exemption known as Section 56 to the Canadian Controlled Substances Act. So from day one, in Canada, supervised consumption sites were legal federally. In the United States, that is not the case, and it is up to cities and states to really lead the way within a very murky federal legal context.
Brendan, be
yeah.
conscious of time.
Great.
please.
I'll say one more thing and close, which is that this makes it very difficult for staff and volunteers working at supervised consumption sites. They're frequently threatened with closure or even risk of arrest in some settings. So I think we need to think about people who use these sites, but also people who work at them, and the challenge that this paradox causes in terms of their ability to provide the most effective care to people who use drugs. Thanks,
Thank you.
Michelle.
Thank you very much for these insights. Our next speaker will bring a broader European perspective, and this is Roberto Perez Gallo, who works with Correlation, European Harm Reduction Network. Roberto.
Yeah, I don't have an easy perspective or position to be, just because Sally is asked to do a global view in specific things. But when asking to examine the idea of a paradox, to me, what was coming to my mind and reflecting in conversations is how we can be observing drug consumption rooms as both care and support facilities fixed in particular places, but also we can be looking at them as globalized, mobilized drug policy models. And there is always a tension in there, which is interesting to explore. So from this global relational perspective, DCRs become almost like an assemblage of reference points and parts from elsewhere that resonate with and condition some political discourses and policymaking practices that are looking globally for inspiration and for legitimization of what they are doing. Also through this lens, we see how drug consumption rooms are also shaped by the molding of generalized and abstract models that are implemented through mobilization, advocacy, and translation processes into concordance with particular local priorities. Also, because that capacity of finding legitimacy, drug consumption rooms oftentimes are put into work as a way of triggering or opening up certain discussions or reflections on drug policy reform. But if we look at it through the other lens, drug consumption rooms, particularly unsanctioned ones, also can be seen as a local response to a quest for generative justice with the capacity to generate alternative forms and infrastructures of support that they are building on collective self-experimentation on bodies, substances, materials, technologies, and relationships of care. And these experimentations are essential not only in forming communities of people who use drugs, but also have become the base for what now we are understanding as a common biomedical and care responses to public health and drug-related emergencies. For example, peer witnessing or accompanying consumption is something that people who use drugs and people who care about drugs has been doing for decades, even before the first sanctioned drug consumption rooms were established. So looking back into these current processes is allowing us how drug consumption rooms are bringing these two dimensions of interrelated and almost co-constitutive areas through a series of multiple and simultaneous forces on local, regional, national, and global levels that require a lot of fine-tuning, and how most of the times these processes are not synchronous between what's happening in the communities, other people who use drugs, local communities, or policy, or oftentimes the power relationships that exist within them are not completely equitable. So sometimes it feels that we go back into this old discussion that we're having into okay, what are we understanding as harm reduction? Are we understanding harm reduction as a value-neutral public health intervention that is satisfied with reducing the harm that neoliberal societies are producing, just focusing on ensuring right to health? Harm reduction is a right-based, systemic changing, social justice-based approach to drug use and drug users' liberation. Perhaps in the field of drug consumption rooms, there is attempts to overcome a tiny bit this, or even reconcile this binary, in many of the new practices that we are observing that they are happening. And perhaps we have the possibility of starting to look possibilities in which we can be combining a bit of a risk environment approach to harm reduction with a relational understanding of a place-based healing potential based on the communities that actually are taking care of this. So for a while, One of the things that we see in many examples that they are happening is that there is people that they are moving away from drug consumption rooms as a concept, as a model, or as a category of service provision, and they are moving themselves into finding relationships between these structural produced harms and local produced well-being by the people who use drugs. So while public health has been fostering a lot of support and a lot of capacity for the evaluation of the effectiveness of harm reduction interventions, also has provided tools for actually improving certain care practices. Also, we see that this biomedical approach has been heavily relying on discourses on healthcare, framing harm reduction as a means to disease prevention. On the other hand, basically we see that in this landscape of TCR mobilization, implementation, top-down public health approaches lack attention for the local conditions of neighbors oftentimes in other communities, but also to other methods of consumption. There is an overly focus on injecting drug users when there is other substances that exist. There is other local conditions. There is still women who use drugs, even in places in which there is drug consumption rooms in which they are not having access. So this lack of attention for those conditions and other forms of care actually are generating the possibility of perhaps moving forward in a different concepts. We are moving a little bit with that, which is a bit the notion of safer consumption spaces. The idea of like departing from place and conceptualize how the places of drug use, rather than building on models of public health interventions, can allow us to make visible specific socio-cultural conditions that they are permeating the harms in this place, but also allow us to emphasize the therapeutical potential that may emerge out of the grassroots and organic responses to these adverse conditions. So in this particular case, I don't know if at a certain point it's a question of like public health, as much as public health is supporting in moving forward from a particular criminalizing discourse, but the idea into how are we creating healthy publics. And this notion is something that for us is becoming really important, because the idea of healthy publics is bringing us forward, in the case of drug consumption rooms, into a redistribution of expertise, not that much into a misalignment between the public, in this case the community who use drugs, the people that they are living in these areas, and the experts, but much more to shift this focus into people as targets of interventions and into a redistribution of power of knowledge, capacity for care, and to generate local care practices and conditions for health informed by the collective expertise and experiences. And perhaps
Roberto?
with this capacity, we can be generating safer spaces for people who use drugs that move away from these paradoxes.
Thank
I'm
you.
done.
Thank you very much. And our last, not least speaker is Hugo Faria, who works with Ares do Pinhal, an NGO based in Portugal, and he's been involved with the drug consumption room project in Lisbon. And so he will tell us about the Portuguese experience and why did it take so long for a progressive country like Portugal to come to a drug-safe consumption room.
Okay, good afternoon. Thank you for the introduction and for the invitation. So, in fact, well, I'm Hugo. I work for this NGO for some time, and our NGO works with addiction, with treatment, but also with harm reduction in some projects in Lisbon. To go directly to that, when I was challenged to come here to talk about this paradox, I was talking and thinking out loud with Jennifer, and we were preparing this, and I was saying that, well, probably Portugal is not the best example to talk about the paradox, because we decriminalized the consumption a long time ago, in 2001. But immediately, I realized that this is not a good point of view, because that's exactly what we are talking about here today. So this is a paradox. We take 20 years in a country that decriminalized the drug consumption, and even though we take 20 years to open the first drug consumption room. So this really means that paradox like this also happen in countries that doesn't criminalize the use and consumption of drug use. After this, during the process to create the consumption room, this last attempt that started in 2017 because there was some attempts in the past to create drug consumption rooms. But in this last attempt, we also realized that in the final version of the project, we would like to have, well, it was mandatory that we'll open 2 fixed ones in Lisbon and 1 mobile. The fact is that today we have only 1 fixed and 1 mobile because the other fixed one never opened because of the resistance of the neighborhood who was chosen to be the DCR. So this also means that we are dealing with the same problems that in countries where it's when it's prohibited to have a drug consumption, to use drugs. So, in my opinion, because I'm here representing an NGO and talking in my perception, not in a national perception, I have to say that, in my opinion, this happens because of some misinformation, some misunderstandings, some myths around the drug consumption rooms, and also because these places are somehow, and I don't know exactly why, well, we could talk about it, but these places are evilized, so they are seen as something evil, where something evil happens inside of those doors. And some myths around this, and I will say some of them that in my opinion are important, are these places usually are seen as places where we promote or that promote the use of drugs or that promote people to use more drugs. So this is not only strange, I could say that there is a bit of ridiculous because these places happen or open because there are people that use drugs. So these people were there before. So we open because to serve, to support, to give something to people who use drugs. So it's almost the same that to say that hospitals, when we open an hospital, we are promoting or are asking people to become sick only because of the reason that they're in hospital. So it's so ridiculous like this. So the other thing is, in my opinion, is that in some places or in some minds, these places are seen as the end of the line. So like if it was some failure in the process of treatment people. Like we are giving up to treat people, but the key word is treat people, because we cannot look at people who use drugs only with the objective of achieve cure or treatment. So we have to understand that these places exist not as a failure, but because there's one more option to provide specific services to specific populations. So that's only that. And the other thing is that in Portugal, when we decriminalized the consumption and the use of drugs, we were not accepting that people could use drugs. So what was the population and the politicians was saying, it was that they don't want or doesn't make sense to arrest someone only because of he's doing drugs, he's a drug user, or people use drugs. So that's the only thing that happened in Portugal, because the population and the general population, I know that it's difficult to know who is the general population, but people don't want the same today, or doesn't accept, or is difficult to accept that people use drugs. And this is very...
Hugo? Sorry.
Yes, and then I will finish by saying that to promote or to start this evilizing around the DCRs, we probably can say that we have to admit that this is a place where we can promote dignifying conditions, but also as an health, we provide benefits in health, in the personal health, but also for the general population. Even if it's the model of the DCR, can be more or less clinical, but we are always promoting some kind of health benefit in people. That's it.
Thank you. Thank you very much for pointing out that some of the specificities of Portugal. I guess we could take 3, 4 questions. I'm looking at you, Philippe. I see I'm looking at the clock, but we started a bit late, and this is such an important and contemporary topic. So let's open it for 3, 4 questions, and then I'll ask the panelists to answer one or several of these questions. So please, yes.
Hello, my name is Gabi Becker from Frankfurt in Germany, and my organization is running 2 safe injection rooms in Frankfurt for nearly 30 years right now. And I have another paradox to add, because we reached our goals. 30 years ago, we had 192 drug-related deaths in Frankfurt. Now it's decreased to 20 drug-related deaths per year. And HIV and hepatitis C rates have gone down, and the average age of our clients have raised from 25 to 42. So everything seems to be fine. But as you know, politicians never are quite okay with what you're doing. Now they are expecting us to take care of the public space in front of our safe injection rooms, so that we are responsible for law questions, for them to behave okay, to go to a different place, not to stay in front of this, and we are not accepting that because we are part of the help system and not the legal or illegal system in taking care of that. So I'm wondering how it is in the other countries. And another thing I want to add is that we should take care of drug checking in drug consumption rooms, which is very necessary and which is very difficult. We are trying now to get it in Frankfurt, but I'm not so sure if we can handle that, but I think that's necessary for our clients. For example, we had drug monitoring, and the heroin, for example, is between 8 and 12% of what clients are taking. So it's really necessary concerning consumption Schutz.
Yeah.
Okay.
Thank you for these 2 questions.
Yeah.
Let's take a few more. Any additional question? You raised 2 important points. Okay, so let's start with you, maybe Hugo. What about Portugal on the environment and on the drug checking?
Just a comment regarding because it's very curious. We take a long time to convince people that DCR is needed, and when we are able to open, if we are, then everyone expects that we solve the problem in many points of view. In an individual and health point of view, in the community, in the judicial and social. And then we are not only pressured by, and I talk in the name of the team, we are pressured by the daily work, but we are also pressured for the others that want to know why are we not solving the problem. But we don't want to solve because we are not able
to do it.
To solve because probably there is not a solution for that. And about the drug checking is also something that for me and for us, it's very clear that it is needed, and it's a very important support to our practice. But it happens the same, so we had a protocol with an institution that operates in Portugal, and they had a mobile project that could come across Lisbon, even to work with our DCR and another one. But the funds stopped, so now we are like with closed eyes to the substance.
Sorry, the funding was coming from where?
from the National Institute for Drug Addiction.
Thank you. Let's go to France, US, and then Roberto, a short comment from everyone. Yeah.
It's more comments on a direct response. I think that one of the problems in my country, but I also think in other countries about drug consumption, about the fact that we have difficulties to sensitize government to implement drug consumption rooms, is also the way we frame the discourse about drug consumption room. Sometimes the way we frame the discourse about drug consumption rooms is it is a solution. And the problem in France, for example, is that there was a lot of confusion about there was not enough communication about what are the aim of drug consumption rooms. And for example, a lot of residents think that if someone attends a drug consumption room, he will become abstinent. And as the residents and some member of the government see that in our scientific evaluation, we don't evaluate abstinence. We evaluate the decrease of at-risk practices, the decrease of overdoses. Some residents were very surprised and say that well, we at the beginning we accept to have drug consumption room because we think that there will be no more injecting drug users in our area. But that's not the aim. For aiming that, we need to have a more comprehensive view, a more holistic view, and to have what we call now in France halte soins addiction. That means drug consumption rooms that also include access to drug treatment, access to social inclusion, and drug consumption room itself is not the solution for all things. So we need to think about how we communicate about this topic to sensitize the population and to be very specific about on what it works and on what it doesn't work.
Thank you. Brendan.
You stole my words. I completely agree, and thank you for that question. It's particularly important, I think, as we move towards implementation, to be clear about what these facilities aim to achieve. They will not solve a massive unaffordability and housing crisis in an urban center. They will not solve America's fragmented and wholly inadequate substance use disorder treatment system. So they need to be paired with many other strategies to address the overdose crisis overall. I think scale is important too. 2 overdose prevention centers in a city of 8 million people will not reduce overdose deaths by 40%. It's just not possible. And so to set those expectations, and I completely agree to clarify what are the aims, what are the goals up front so that the public and policymakers don't have unrealistic expectations is absolutely critical. So thank you for your question. I completely agree.
Roberto.
Totally in agreement. Definitely, drug consumption rooms are affected as an integrated part of a comprehensive package of care, including housing, including basically all the things you have been mentioning in there. There is an element in there, though, that still sometimes remains, which is the question of integration within the areas in which drug consumption rooms are going to be implemented. And I don't want to come back, but this idea back and forth of like oftentimes, in many neighborhoods, it is experienced as a top-down decision that comes in a particular neighborhood for reasons. And there is oftentimes a lot of histories in these places that lead to complications that also put forward tasks to drug consumption rooms as a way of evidencing that they are going to bring in positive effects in the neighborhood, like cleaning, working around. As a quick, simple example, there is different ways of also approaching this. For example, one of the things that was in Barcelona was a really beautiful example. There is in the municipality of Barcelona, there is a department that is called anti-rumor department. And then in the moment that they implemented a shelter for people who use drugs in which consumption is allowed, for smoking and for injecting. And there was like a huge resistance that happened in the neighborhood. And one of the things that they realized is that in this neighborhood, there is a big history of trauma in relationship to drug consumption from previous years ago. So during a long, long time, what they started to do is basically to infiltrate, I'm not going to use this word, but engage in conversations with neighbors and slowly trying to understand what the resistance is in such a way as to basically understand that the problematic is not specifically on these individuals, but on a bigger scale, and collaborative solutions need to be found. So in that moment, other type of resistance also were taken away, like the idea of perform a visibility of improvement of the neighborhood was completely removed and taken away because everybody was more on board on the way that that's the role that the drug consumption room is having in the neighborhood. So there is many different approaches, neighborhood commissions, we can unpack them all later if you want.
Thank you. So this brings us to an end of this wonderful session. Please join me in thanking our panelists. I take it from what we heard that supervised drug consumption facilities are a powerful, non-biomedical harm reduction and overdose prevention intervention that really gives a primacy to autonomy, to the well-being, to individual and public health and social inclusion over other considerations in drug policy. So we need more consumption rooms. We need more evidence because we need more evidence in order for this to become a WHO recommended intervention in harm reduction, which is still not yet there. And when we get to that being a recommendation, we then have to go to the next step, which is that it becomes policy. So a lot of work for each and every one of you, wherever you work and in whatever is your way of contributing to pushing for reforms of drug policy. So please, join the movement, keep up the fight, you're on the right side of history. Thank you.